Hey guys, and welcome back to another episode of Surviving Out of Spite. My name is Samantha Sauer, and I'm your host. Today we have a very special episode for Awareness Month. One of our newest members of the Medical Advisory Board joins me today. We're going to talk all things communication and advocacy and different gastroparesis treatments. Talk about tips on how to talk to your doctor, and even a deep dive into the G-PACT, a very promising procedure that's helped many patients like myself find relief. We are covering all of it. We also explore what the future holds for treatment and how patients can stay empowered even in this broken system. Stay tuned. Well, thank you, Dr. Hida, for seeing and being here with us today. I want to give you a chance to introduce yourself to our audience who didn't attend our first virtual conference because you did speak there. So for those who are unfamiliar, I'm sure they would love to get to know you a little better.
Sure, absolutely. My pleasure. And thank you for having me, Samantha. So my name is Hida. I'm a advanced interventional gastroenterology trained physician. I went to St. George's Medical School and I trained at NYU Langone in Long Island for a total of 7 years. And here I am. My passion is advanced interventional endoscopy and treatment of difficult disease processes. Combining up-to-date literature and evidence-based medicine with advanced therapeutic procedures and bringing people back their quality of life and treating their underlying disorders successfully as much as we can.
Yeah, now probably no one knows. I'm like, for those of you that don't know, but nobody probably really knows that you were my physician a few years, more than a few years ago at this point.
Right.
It's funny because I tell this story a lot in different aspects that I've done on the podcast and with other people that appointment, you were not supposed to be my doctor that day. And I think whoever was supposed to be just wasn't there. You came in the room. I'm like, who is this guy? Like, that is not who I thought I was getting. And I just bawled my eyes out to you. The first appointment, I'm like, hi, my name is Sam. And here's my whole life story. A total mess. And you handled that like a pro. There was never a moment in that appointment where I was like, okay, he thinks I'm crazy, which you might have, and that's okay, but you never let me know that. And really just heard everything that I was saying. You understood my fear, you listened to me without judgment, and really helped me make a plan going forward. Now, this is probably putting you on the spot a little bit, but that's not always the experience that most people get in these appointments. So I guess, like, from my perspective as the patient, knowing I just blubbered and just threw everything at you in one fell swoop, you really didn't make me feel like I was being unheard and you took me seriously. Like, what do you do when you go into an appointment and you have a complicated patient like that? Like, what is your first thought on how do I treat this patient?
So I definitely remember our experience, the disappointment in your face. And I have to tell you, it's very, very common that the higher trained you are and the more far along you are in your physician-patient relationships and experience, that you will have funneled these patients that are quote unquote deemed as crazy by other physicians. And really that's just a reflection of their frustration, lack of confidence, and lack of know-how on how to deal with those patients and how to truly deal with the underlying condition. It is frustrating when you get a patient that has seen, as per your experience, 12 other physicians, and they're, in their mind, they're like, oh boy, here we go again. What's going on with this patient? What do they want? Are they drug seeking? Are they this? So really the most important part is to be prepared as a patient. If you want to have a good doctor-physician relationship, you really have to be prepared. You have to know your disease process, your symptoms, have some sort of a log book or something to be able to detail the steps that you have taken along the way, the procedures that you have had done, the medications that you have tried. Be your own best advocate and present to the physician, who also, of course, has to be interested in your disease process and helping you, what you have and where you'd like to go with that. The most frustrating portion of your introduction to a new physician is not knowing what's going on with yourself and trying to leave that to the physician to figure out.
Yeah.
Because we don't know where to start. And when we generally start with a patient like that, we start with, evidence-based medicine and what's been proven. We don't know if this is IBS, so we really have to start all the way from the beginning and put you through everything that you may have gone through or experienced before, because we don't have that information from you. So be honest about your symptoms, your medical history, your life choices, concerns, questions, any of that, and have those for us. At the same time, you have to understand the medical culture is very different nowadays than as it was 10, maybe 20 years ago. Physicians, for the most part, in private institutions and large institutions, tend to have a very limited time with their patients. So we come in with, a chart that says gastroparesis or nausea, vomiting, and we're looking at, okay, well, there could be a billion things involved in that. I don't really know what I'm looking at or what I'm getting into. Yeah. And so we have kind of a preconceived notion of A through Z of what we'd like to advise you and the types of questions that we have for you. And we kind of zoom through that really quickly because we have a lot of knowledge. We don't have any knowledge of you, but we have a lot of knowledge about that symptom process. So, in an academic situation where the physicians are, I want to say paid differently, but they're structured differently. They don't have to worry about that time. So that time is your time. And we could see 3 patients a day, we could see 30 patients a day. And so if you're truly interested in that disease process and in your patient, you will take the time to listen and to formulate a unique and individualized medication and treatment approach to that patient rather than a canned, generic response to every patient.
Now, with that, and we talked about this not that long ago, what I felt I needed in my next step, or what I wondered was my next step in treatment process, wouldn't have been your first choice in treating that, going by, like you said, evidence-based, or maybe in a normal structure. That was not something you would have said, yes, let's just go do this as your next step. And I had been septic multiple times, wanted to get off of TPN, and we ended up trialing tube feeds, which worked for me. And I remember being able to, I think it was maybe like 10 months later, I did my first road race running a 5K, which I would not have been able to do if you hadn't have listened to me in the beginning. And I think about that a lot, where maybe that wouldn't have been your first choice. Maybe it's not something that would have been ideal, but for me and my comfort level and what I felt that I wanted to try, we did try it and it worked. That said, we did end up going to what you wanted to do and to talk about in the beginning, which worked even better. But it was a process for me that I think it's not going to work for everybody. And I'm not saying that it should be how it works for everybody, but I think going about it the way that we did allowed me to be mentally and physically more prepared, and maybe help the G-PALM work a little bit better. That could be just how I have to think about it. But even now, I was stronger, I was healthier, and mentally I was in a place to say, let's do this. I want to take this next step. I'm ready to make this next step. Where in the beginning, when we first met, I was mentally and physically absolutely not ready to make that next step because of the permanence of that procedure. Scared the crap out of me, and I just wasn't ready for that. And you heard me say that, and it just, getting me to where I am now too, being able to eat a little bit more, having the success with that treatment. I think all of that goes back, or a lot of it goes back to that first interaction of the patient trusting the doctor and the doctor hearing the patient. It solidified that relationship that allowed me to get to where I am now.
Right. And so, I remember, you're a very different patient, Samantha. So you were very determined. You knew what you had gone through and you had documented that for yourself. So you came in with a lot of knowledge about your disease process, which can certainly be very intimidating to some physicians. For someone like me, I knew where I wanted to get you to, and I've understood and listened to what you were going through. So instead of kind of going, A, B, C, D to E, I just kind of wanted to go from A to E. But It's very important to listen to your patients, and it's very important to have this be their medical journey and not yours.
Yeah.
Yes, we know what works, we know what doesn't work, but there's never 1 + 1 = 2 in medicine. There's so much variability. Every single patient is unique. What works for one will not work for another. So we try to do our best to figure out and funnel and select with patient selection criteria what is most likely going to work for you, test that out. And really only when we have the evidence that this will work for you is when we can advise you of what we would like to try. It's still your choice. It will always be your choice. And whether you agree with that or not is completely up to you. And we cannot force nor want to force anything on you. I remember my hospital, most hospitals in the area have never had a procedure like that done before. They were completely unprepared for what would happen after. I remember the surgeons who were somehow involved in your care as well wanted to open you up because you had pain after the procedure. Not only did I say absolutely do not touch her, but you said that yourself. People have to advocate for that because
Yeah.
they're confused. And if you don't have that trust in yourself and your physician and what's going on, then God forbid you would have gone through other surgeries, you had adhesions. I have no idea what would have happened with surgeons that are so indoctrinated in what they know and think that they can expand that to what they don't know. They've never talked to me about that except for the fact that you were having pain and they wanted to go in, and I said absolutely not.
Yeah.
So that makes a big difference. Knowing what you want and making that a combined journey, for yourself and your physician. And your physician is not a god. They're just someone who's very highly trained, who's studied a lot, has seen a lot, and can offer you some options. But the options that you're comfortable with going with will always be yours.
Yeah. And I think, like I said, with the medical trauma that I've been through, before we met and what's happened in my life since then, that dictates some of my choices and some of what I am comfortable with, and the permanence of what we did end up doing that did work. But the idea of that permanence scared me more than anything because, back when I had my thyroidectomy, I thought I'm about to get my life back. Like, I'm making this choice. This is permanent. This is like the last thing that I can do. This is going to be the best, and essentially became my only option. And I'm like, okay, I'm ready to get my life back. And it snowballed my life in the complete other direction. So just that alone, and hearing that, even if I didn't outwardly say, hi, I'm Sam, I have medical trauma and permanent, surgery scare me, you can hear that from the patient without them actually saying that, and realizing when their records are 10 feet tall because they've been through so much, you can almost assume they've probably been through some shit. So they might take a little bit of time, I don't want to say coaxing because that sounds bad, but like conversation with the person before you get to that space. And, for me, it was incredibly successful. And anytime anybody asks me about it, I'm like, I'm not telling you to go get it, but I'm also not going to tell you not to go get it. Talk to somebody. Make sure that they have experience like my surgeon had, because as you noted before, not everybody who can do the surgery should do the surgery, right? They don't have that experience, or maybe, I don't want to say that they'd be careless, but they don't have that same precision touch that, someone who has done this as many times as you has. And that's really where you want to go.
Yeah, there's no question about that. So I remember one of the first things that I offered you, you wanted a Mickey peg. And because you're a runner and you're athletic and you don't want to run around with, a tube flopping around, and you wanted something that was profiled for you. So that made complete sense to me. I offered you Botox, and you said, well, you already got Botox and it didn't work for you. And I said, in the back of my mind, it's like, yes, that may very well be true, but I didn't do your Botox. And as I tell my colleagues who are surgeons multiple times, I said, just because you know how to do a Heller myotomy robotically doesn't mean you're going to get the same results that I do. And many times they do not, because they do not cut all the way through. They do not do the procedure the way we do it. And so we have a lot of redos. And so I remember when we did do the Botox and we did it the right way, you benefited from it and you had a positive experience with it. So
I sure did.
Right. So that's the thing. So that's how we do selection criteria. Your underlying issues were autoimmune, and autoimmune everything to get bad. And generally, this unrecognized etiology of gastroparesis can very well be autoimmune, even when something autoimmune isn't found. Yes, there's neurologic, there's diabetic, there's all kinds of different reasons why. So idiopathic just means, well, we don't know, but
Yep.
there's a reason. So we have to figure it out. So, we don't know is not good enough for a patient that really wants to know what's causing their issue. So we have to do this patient selection criteria and go from dietary modification, lifestyle modification. What are your medications? Do you have diabetes? Do you have prediabetes? Is it Lyme disease that's causing this? Is it another autoimmune disease that's causing this? What's causing the problems? And then even if we have no answers from any of that, then we trial things out. We trial diet, we trial Botox to see if you respond. And then we can, categorize you. Well, you responded to Botox, therefore you should respond to a G-PACT. You didn't respond to Botox, you may respond to a gastric pacemaker. So there's a lot of different options and different ways of doing this. But stepwise approach is the best. You don't want to go from the earth to the moon without going in between. You have to go through, because not all the solutions in medicine are permanent. Some things you do well with, but after a while they may relapse or they may come back slowly. There's tachyphylaxis and medications where you get used to the medication effect and then your symptoms come back. There's a lot of different things. So we want to be able to go through that process so that we can give you as much time for quality improvement of your life than do the most extreme and then really be stuck with not really having many other options because we went from A to Z, without going in between.
Yeah. We've talked a lot about trial and error, just mostly in diet modifications, but in everything you're mentioning too, that it is incredibly frustrating. Like, because as a person dealing with this, especially anything around food or not feeling well in general, you want to feel better. Like, you want an answer, you want a medication, you want something that's just going to improve your life. And we all know that it doesn't unfortunately work that way. And sometimes you have to go through that trial and error process. And, when you explain it the way that you just did, I understand why you would put me here and then move me here and then move me here. Like, I understand that entire process. But I think that because it doesn't get explained in a way that patients understand, and I've been on the other side of that, where someone's telling me something and I'm like, I consider myself a relatively, educated patient. I've been a patient and having chronic illnesses for a long time. So when I'm sitting here, I'm like, I don't understand why you're doing this to me. Not to say that that's not on me, but it's also on the communication style of how it's being presented to the patient. Are you putting me in this trial and error just because you don't feel like dealing with me and you're just going to throw this at me? Or are you doing this because there's a real reason why you're starting me with A instead of moving me to E, F, or G? And sometimes it does warrant jumping, like we did with me. Sometimes those things are warranted or they will work, but it's not without conversation and it's not without both parties coming to that same conclusion. And I think the communication, especially around GI, at least with a lot of females I've spoken with as well, that's not always presented in a way that we would feel safe starting from A to B. You just feel like you're being dismissed. It's like, here, take this medication and come back in 6 months. Well, that doesn't help me. This didn't work, but you didn't answer my portal messages. I couldn't get in touch with you. Then take this other medication, come back in 6 months. And your trial and error has now extended over years instead of what could have been months, because you're not being able, you're not able to reach the doctor, or they're overwhelmed. We know the medical system is completely burnout. You all have hundreds of patients and you're human too, and you get burnout and have to take care of yourselves, but it leaves the patient essentially in a spot where they just are not feeling any better, feeling unheard. And we all know once your mental state starts to kind of not be as positive, or you're not feeling as like stubborn and wanting to really fight this, it doesn't make the healing process any better, and it doesn't leave a healing environment for the body or for the doctor-patient relationship either.
Absolutely. I think one of the most important things to do is kind of feel your physician out as well. and definitely make sure that you are being heard. And if you keep your medical chart just like the physician keeps theirs, and remember, your physician might have 5 minutes to look at your medical chart before your appointment, so they may or may not remember you, and they may hit the right bullet points on that chart or not when they see you. So multiple frequent appointments are important. That develops a patient-doctor relationship. They'll be more apt to remember you, especially when you have your own gradation system and say, well, doctor, this is what you recommended last time. I tried this and this is how I feel. I think maybe some, benefit from that, but I don't think it's as much as I'd like to. I'm still having nausea. I'm still having vomiting. Because of that, I'm not eating as much. I'm losing weight. I'm not able to have enough energy. So be very, explain yourself, and speak out of your own experience, and make that physician listen to you, really, without having to be confrontational. And I have to, say that any physician who feels bothered by what you're asking of them, whether you just Googled it in the waiting room or you did some research on your part to understand it, that is not a challenge to the physician. That should be taken as, well, I understand that you read that information, certainly is available online about that, but let me explain why they say that or why they don't say that. That would be a proper way for a physician to address you. They may not have 45 minutes to speak with you, but at the same time, I say, well, let's cover this today. Let's try to figure this out. Let's get you out of here with something to try that's new. I'll look into that as well. And then let's make another appointment, see how things are, and slowly progress and build. You will not ever be able to resolve your issue with one appointment. You will not have
Absolutely.
It's not going to happen. So multiple appointments and building is what's important, because you don't want to start from stage one every time you see your physician.
Yeah, no, that's true. And I think, in the last couple years, even again, for myself, I try to be as prepared as possible and go in to say, this is what's working, this is what isn't. But again, when things are overloaded and you're shuffled in and out, it's hard and to really feel like you're being heard. And I think everything that you've mentioned today for a patient to do as a physician, to say, these are the things that I need to treat you well, hopefully that's something that will benefit patients that maybe didn't realize that that's something that they could or should do, that would benefit them in the end going into that appointment. So I think that it's good to hear that from the perspective of somebody who's saying, this would help me help you. This is what I need in order to treat you best. And this is the best way for me to make decisions for you, or help make decisions for you, I should say. But
Absolutely.
I did want to ask, even though I know, but I know not everybody does, with the G poem, if you don't mind explaining how it works a little bit, or what it means to have a G poem. I know we talked about what makes a good candidate, but the actual procedure, surgery itself, if in layman's terms, if you could explain a little bit of that, I think that would be very helpful.
Sure. So in the process of gastroparesis, there are multiple things involved. So the majority will have a subset of symptoms: pain, nausea, vomiting, abdominal distension, dyspepsia, things like that. Mostly symptomatic things that may or may not have to do with actual motility of the stomach. So what we have to figure out is it a motility issue, or is it strictly a symptom issue? Which is, you can see some of those medications that are out, that are, or at least are in research, like the tradipitant, which is a medication that acts on the area of the brain and tells you there's no nausea, even though you are having nausea. So in that process, in that patient selection criteria, what we find is that a good number of patients, I would say maybe 63 to 75% of patients, do respond when the stomach empties quickly, which is what the basics of diet come in. Multiple small meals a day, meals that are not high in fat, not high in fiber, because those things make it more difficult for your upper GI tract to move things along. And most of this is concentrated in the upper GI tract. So if your stomach can process a small amount of food that is not difficult for it to expel into the small bowel, then the majority of those symptoms will not be there, because a lot of those symptoms are not necessarily because there's something wrong with you, but because your autonomic nervous system is interpreting those signals from the stomach as something's wrong. Things aren't moving quickly enough. Even just sensation of the stomach being distended normally is an abnormal signal to you. And so the symptoms is the same, whether there's something wrong or not. And so that's what we have to work on. So in patients that are responders to Botox, so what we do is we inject Botox in a circular fashion around the pyloric muscle, which is really a shutter gateway sphincter muscle that allows food that is almost liquefied to leave the stomach and enter your small intestine. A lot of times food sits in the stomach for a long time because it's slow moving and it's not going into the small bowel. And a lot of that is what causes symptoms. So when we inject Botox into that muscle, we paralyze it open. Muscle cannot close, it stays open. And if you're having a symptom improvement, saying, my God, I feel so much better now, that will last for about 2 to 3 months. And then the body clears away the effects of the Botox and you're back to where you were before. But if in that time you can tell the physician, wow, I feel so much better. So we quantify that. Is it 40% better? Is it 60% better? We want to see how much better do you feel. And again, you have to remember, placebo is 30% of your symptom process. If the doctor tells you you're going to feel amazing after this drug, you will not have any symptoms, you'll be amazing. Here's a Tic Tac. And you say, yo, you're right, I feel a lot better. That's 30% of your placebo. It's your mind telling you, wow, this medication is, magic bullet. But it's a help. And you have to keep that positive attitude. So if the Botox helps you and gets rid of your symptoms, or at least takes away a large chunk of that, what that tells us is that keeping that gateway open permanently will get rid of a lot of your symptoms. So surgically, what we do as a minimally invasive surgery from a gastrointestinal perspective is we basically make, your intestine has 5 layers. So we burrow onto the very first superficial layer, which is the mucosa. It's the tissue that touches your food. We get underneath that, and then we cut another layer, which is the submucosa. It looks like a spider web of cotton tissue. We get rid of that as well in the tunnel until we go above that pyloric muscle. And then we cut 2 separate layers of muscle, circular muscle layer and longitudinal muscle layer. And what we leave behind is the very last layer that is the barrier between your intestine and your stomach and your other organs in your body. It's a very delicate surgery done only by people who have a lot of experience in this. And then we close the tunnel entrance because that's our safety. If a perforation is made, we close it, no problem, start somewhere else. So when we close that, and we cut those muscle layers, now your pyloric muscle is permanently cut. So it can no longer close. It can squeeze, but it's called a keyhole deformity. Basically, that bottom part of the keyhole is where a cut was made, and your stomach, your gateway muscle can no longer close. So what your Botox did for you will now do it for you for a very long time. And your symptoms, combined with how you feel about what the procedure was, the placebo effect, and the fact that now we've opened that gateway permanently, is going to help you quite a bit if you are someone who responded to the Botox because your gastroparesis symptoms were mostly caused by the effect of food sitting in your stomach for a long time and not moving along.
Now, I think, if I remember correctly, now I had mine back in 2018. So it's been a good while that I've been able to eat still within my parameters. And I think that's something that we see a lot as a misconception, that like the G-PACT will cure your gastroparesis, right? That like somebody goes from not being able to eat to being able to eat like you're cured. And I know that I've had days, and I've said this a couple times, where I forget that I have gastroparesis because I had a really good stomach day, and I've had that for extended periods of time where I do really well. But I also am very careful to stay within certain parameters that I know these foods generally don't flare up any symptoms. Like I still have flare-ups of symptoms. I still have days where I can't really eat anything or food might sit a little bit. But overall, comparatively to where I was relying on TPN and or tube feeds to being able to sustain my life and my nutrition based on what my intake is, that's a huge difference. And it's been really helpful to be able to eat again. But it took me probably a good like 3 months, I think, if I am remembering right, where I went from soft food, still on liquids and no citrus. I remember you telling me that. I made the mistake of having a citrus popsicle, and that did not go over very well. Think like popsicle, great idea, not the citrus. But going from the liquids to the soft foods to a little, more solid foods and kind of moving into that, it was a process mentally and physically. Because like you said, if you go into this thinking one thing, like you're stopping it before you even get a chance to start. So I really tried to, go into that with, okay, I'm going to give this a try and just see how it goes, and then we'll move on and kind of keep doing that. And it got me to be able to eat somewhat normal again. But I think that because it works differently for everybody and everybody's outcome is on a level of how much they can eat or how little or anywhere in between, that it's hard for someone on the outside as a patient saying, well, where am I going to fall on that spectrum? Am I going to be able to eat like this person, or am I going to be able to eat like this person? And it's hard to make that jump because you don't exactly know where you're going to fall. And I think kind of coming to terms with that is a hard thing to do, because again, you just want to feel better. But for the most part, the majority of the debilitating symptoms, the G-PALM, once completely healed and getting to the right place, it removed those symptoms. Doesn't remove all the nausea, which I wish it would, but it doesn't remove all the nausea. It doesn't remove all the flares or all the symptoms, but it allowed me to function. And I couldn't be more grateful. I mean, I know I've told you that a bajillion times over the years, that I wouldn't be here if you hadn't have come into the room that day. Because if I had seen somebody else, if I had somebody else perform the procedure, if I had somebody else come in and be like, she's crazy, I'm not helping her, or like, just take more Zofran and just like get out, or just stay on tube feeds for the rest of your life, that intervention completely changed the entire course of my life. And even though I know not everyone can say that, I will never not yell that loudly, because I think that everybody needs to really, not everybody, but really take that into consideration. Like, am I a good candidate for this? And if I am, what's my next step? How can I get to that place? Because I don't know where I would be if I hadn't have had that done.
Well, and I appreciate you saying that, Sam, because to me, and it should be to most physicians, but having a patient change their life positively because of something that you've advised them to do or something that you've done for them is really where our satisfaction in medicine is. It's a job like any other. It involves tremendous amount of training and intellectual processing, but at the same time, your reward is that your fruits of your labor resulted in your patient feeling better. And you've made something happen that's positive for them, because we all know when we feel sick, it's terrible, and all we want is not to feel sick. So when we're back to our homeostasis and our baseline, that's where we love to live our lives. And when something interferes with that, we're miserable. And the thing is, with treating a patient with gastroparesis is kind of climbing up a trunk of a tree. So you're climbing up that trunk of a tree because you have a direction in your mind, but then you're all of a sudden branching out millions of different branches. Like, where the hell am I going? And you have to start pruning those branches, because not every patient is a different branch, and you cannot go down the same path every single time. And there's easy to treat gastroparesis patients with diabetes, where they have neurological damage due to small vessel disease because of the diabetes. Okay, so you advise them to control their diabetes, and you can give them propulsive agents like metoclopramide, and that speeds up their emptying, and that's the process, and they feel amazing after that. And it's up to them whether they're going to continue and take your medical advice and look at their blood sugars or not, or they're going to go to the point where it's irreversible and then we have to do something different. That's easy. But that's not medicine. Medicine isn't easy. You have so many other factors involved, and some of the biggest factors involved, especially that concerns neurological symptoms and autoimmune symptoms, is the effect on the autonomic nervous system, where normal sensations translate as abnormal symptoms. And that's where you have to be able to modulate things. And one solution may be okay for one patient, but 13 solutions at the same time may be okay for the next. So whereas you benefited well from the GPOM portion from the motility aspect, it's the dietary modifications you've made. It's the antacid that you're taking. It's probably this next medication that's on the market that's going to tell your body that you're not feeling nausea, that whatever you're feeling is something else. It doesn't feel like nausea anymore. And that's a combination that may work really well for you. But there is no one solution. Some patients do well with 1, 5, 12. Every single person is different. And the most disappointing part of your patient-physician relationship is when your physician gets frustrated and gives up and says, well, I've done all I can do, go to someone else, because they don't want to take their time and say, okay, well, we've done all this stuff. What's the next step? What's the next branch I'm looking at? And that's really what you have to find. And, unfortunately, a lot of that is strictly academia because there's just no time to look at that.
Yeah.
And so people become frustrated with time limitations and also insurance. Insurance companies may say, what the hell? Well, you haven't tried that. Okay, well, how many things do you want me to try for the patient, which is going to overall increase the cost of the medical care if you just let me try this and let me see if this works. So a lot of times your physician has to get on the phone with a peer-to-peer, speak with the other, physician who's making those insurance decisions and, make them understand that this is why it's needed. At the same time, you can tell them, well, I'm happy to do 14 more endoscopies if you'd like to pay for that, or try for this and let me give this a try. So a lot of times you do have to force hands because the goal of insurance companies is not to treat you.
Yeah.
Their goal is to make money and do as least as possible for you to do that. That's not a secret. And that's the secret of pharma as well. So you have to have someone interested and someone who's going to go to bat for you and is going to battle this with you together. And I think that's the most successful experience you can have with someone. You can find someone who will do that.
Yeah. And I know you're good at that because I remember when, because again, this is years ago where not as many people were doing the GPOM or talking about it. My insurance was like, yeah, we're not covering that. You're like, hold my beer. Next thing you know, they're covering everything. And, that's there because you knew that this was the next right step. So you were able to, and you're good at doing that because it's like, fortunately and unfortunately, you have the experience of what that looks like, where not every physician has had to do that, to go to bat constantly for their patients or to fight for certain procedures or medications because they just haven't really come across it yet to that degree, where you have, because you are treating people in, I don't want to say a different level, but like you said, the more complicated patients, the patients that need different things that have already tried. They've done the step therapy. They've done all the other stuff. They've done the relatively easy stuff. And you know what this next step is. So you know how to fight for them. And you're good at that.
It's funny,
but not everybody wants to do that either or can.
Absolutely. When I joined my very first private practice right after school, I was very quickly labeled as the IBS expert. And for in absolutely no way was I an IBS expert, but because I was willing to listen to patients, and this is in private practice, and a lot of my frustrated colleagues would give me their crazy patients, I found out that none of them were crazy. All of them were being sent to me because their physicians were frustrated with being unable to help them. And I would say 85% of those patients did not have IBS. They had other issues that were just not figured out. And so that's generally the situation. And for insurance companies, it's a similar thing. Their claim is, well, this is because it's not a Medicare coded procedure, it falls under the experimental procedure, and companies literally they just parrot that right off of their list, that they have the person who's talking to you on the phone say, well, it's an experimental. Everything in medicine is experimental until it becomes more.
Yeah,
so that argument will never fall or stand with me, because this is what innovation in medicine does. This is not something I just discovered in my basement I'm trying to do on my patients. It's something that has been done, has shown success, and because it hasn't reached the level yet of being accepted as a payment form by Medicare, it doesn't mean it doesn't work.
Yeah.
We do go through the steps to show that this is going to work. So when you force their hand and say, listen, you don't want to pay for that, that's okay. I'm happy to keep doing procedures every week on this patient. Or you can try this because I think this will work and we'll save the rest. But again, you have to have a physician who is willing to do that. And many are stopped at the process of where they're given an appeal form, which is 40 pages, and the physician's like, there's no way I'm dealing with this. I don't have time for it. So request a
Yeah.
peer-to-peer and speak with them. Yeah.
Yeah. It's just it's crazy. Even just with my experience in from start to finish of when I first started having issues, with my thyroid and autoimmune stuff to now. And I think about everything that I've been through and everything that I've experienced. And some of that doesn't even touch what some of the other patients in our community has experienced. And, to hear and have conversations with other physicians and people and physicians that have had different experiences. Like, I know some of yours because I've known you for a very long time and you know my history, but I've spoken to other physicians that, have been through something, they've tried what you're doing and it doesn't work, or they've tried a peer-to-peer or they've tried this and it doesn't work because everything is just not designed for, I feel like, the patient to succeed. It's not really designed for us to understand it. It's not easy to access. And all of these things just make somebody who's already living with a very frustrating disease state even more frustrated. It's all these barriers, that we've talked about, whether it's insurance or it's just cost, or maybe it's distance to a provider like yourself. If you're living in California, you're not easily accessible. That's travel requirement for that patient. And if there's nobody else in their area, but this is something that they need to do, that next step, that's still a barrier. Is that something they're able to do? Or do they have to keep trial and erroring all these other things that probably won't work? And it's frustrating for a lot of disease states, especially rare disease or ones that have limited treatments. But in the last year, it's nice to see that there are more things happening. More people are talking about it. There's more research being done. There's more conversations happening. And, that's what a lot of this is. This is why we wanted to start the podcast. This is why we wanted to do more with G-PACT, to say that, these are the options that you have. These are the people that you can go to. This is the information that we have. We want you to have it accessible so you can make the best possible decisions regarding your healthcare. You don't know how to talk to your physician? Let us troubleshoot that with you. Let's learn how to talk to your physician. Speak to physicians like yourself and hear, what do you want from a patient? What do you need from a patient? So that way we can help foster for the future better patient-doctor relationships, which in the end have better patient outcomes. And ideally that's what we all want, right? So why not do all of these things?
Well, the other thing is a lot of patients tend to be paralyzed and stopped by the fact that their insurance companies won't pay for certain things. But
Yeah.
if you speak with your physician and if that administration is on your side, there's ways of being able to do certain things by substituting or by subsidizing your own procedure. So if your procedure is going to be an upper endoscopy, for instance, and your insurance company will pay for that, the patient can still undergo a G-PACT procedure, which is still done under general anesthesia and it's done in the endoscopy suite. So the cost of that procedure will not be so prohibitive, and the insurance companies may pay for some of it, and you can always supplement the other part because they're not prohibitively expensive surgeries. And so that's another way. There's also ways for insurance companies and pharmaceutical companies to help subsidize that cost as well. So speak with the insurance companies, speak with the pharmaceutical companies. There's always grants and things like that available as well. So there are ways for you to have this done if the insurance is the stopgap at you having the procedure done. If you've gone through the process of figuring out, is this really the next step I have to take, or are there other things that I should try?
Thank you so much for chatting with me today. I know everything. I always learn a little bit. Even though I know stuff, I always learn a little bit. So I can only imagine that everyone's going to take something away from this. So thank you so much for everything today.